Hello, everybody. Hello from Paris. My name is Francesco Maisano, and I'm here in Paris in the PCR studio together with Pepe Zamorano.
Hello.
From Madrid, and with Stefan von Bardeleben from Mainz. And we are going to have the second episode of this webinar series on tricuspid valve interventions. Actually, we have also connected with us João Cavalcante, Georg Nikedi, and Philippe Lourdes, and we will watch a virtual live case which has been recorded in Toulouse from Didier Cechet and Nicolas Dumonteil. I would like to remind you the objectives of this webinar series, which is to learn about patient selection and preparation for transcatheter tricuspid valve procedures, specifically today to get familiar with the most important intervention techniques, and in the next webinar we will focus more on the importance of the heart team and the importance of lifetime management. Before we go into the details of the day, I would like to summarize what happened in the first episode, which I really suggest you to go back and watch. The first episode was run by a panel of big experts with moderation of Marta Stiges and Fabienne Praz. And the team from Clinique Pasteur presented us the case of this lady. This is a 75-year-old female which had been submitted previously to a mitral valve replacement with a bioprosthesis. And she comes back to the hospital in Toulouse with symptoms of severe secondary tricuspid regurgitation, with a preserved left ventricular function, with a somehow borderline function of the right ventricle, with some degree of pulmonary hypertension. This patient is a high-risk candidate for surgery, but also importantly, in the last episode has been discussed, the risk of this patient not being treated of dying is about 30% according to the calculation given from Jan Topilski. Well, this is actually the big discussion that happened in the last webinar, which I really suggest for those who didn't watch it to go back and see it before seeing us. In the last webinar, we had focus on prevalence and prognosis of tricuspid regurgitation in the population, and also we focus on anatomy and on imaging for selection, but also for guiding procedures. And today we will focus on the procedure itself. So it's my pleasure for this day to introduce our first speaker, Philippe Lourdes. From Leipzig, we will entertain us on what are the most important characteristics for selecting the patient. So, Philippe.
Thank you, Francesco. Dear colleagues, it is my pleasure to share some thoughts with you about how to select patients for transcatheter tricuspid interventions. Now, in essence, patients should be or might be considered for transcatheter tricuspid therapies when they have severe or more tricuspid regurgitation, when surgical risk is increased or high, when the clinical benefit after treatment is likely, and when the anatomy is suitable for the device chosen and available. Now, probably most patients will have high surgical risk at the time they are referred for treatment, but certainly not all of patients have high surgical risk. Risk assessment has to be individualized. It requires a fair discussion within the heart team, and risk assessment can probably now be facilitated with newer scores which are specifically designed and validated for tricuspid valve disease, such as the TRI score. Our knowledge about the ideal clinical substrate for treatment is still very much limited. At the moment, there is some agreement about a concept which highlights a certain ideal point along the course of the disease. At that point, patients have some limitations already, but these limitations do not become already irreversible. So that probably is the ideal point in time for treatment. That certainly includes cardiovascular limitations, but also, and maybe even more importantly, extracardiac pathologies, tricuspid regurgitation, systemic disease with limitations for the lung, for the kidneys, for the liver, and frailty in general. Two aspects I'd like to highlight. First, RV function. Surprisingly, TAPSI was not possible to differentiate patients who benefit more as compared to those who did not. And this is probably explained by the fact that TAPSI is a very limited surrogate of RV function. When we look at global RV function using MR or 3D echocardiography, then we see the curves diverting with the right ventricular ejection fraction, a threshold of about 45%. The other clinical point I'd like to make refers to pulmonary hypertension. In blue, you see patients in whom PA pressures were high on echo and on invasive measurements. In red, those were patients in whom echo falsely underestimated PA pressures, and these are the patients who actually do worse, highlighting that assessment should include echo and right heart catheterization, and even more so when we then look at the curves differentiating pre from post-capillary pulmonary hypertension, showing a clear difference with inferior outcome in pre-capillary pulmonary hypertension. Now moving on to anatomical suitability, tricuspid transcatheter interventions. It's all about imaging. Imaging is the most important aspect. We wish we would have images like on the left, would become close to that with transgastric views in the middle, but we also need mid and deep esophageal views to detail the interaction of the leaflets with the device as shown here. Anatomical suitability certainly includes annular dimensions, degree of tethering, but also the coaptation gap. And the gap is so important because it summarizes many of other aspects. You clearly see that these two patients, they are different, they have a different gap, but they're probably also clinically different. And this is why gap is a very important predictor to help differentiating success from failure. And the threshold, the golden number here is probably around 8.5 millimeter. And this is another aspect which is talked about less often is the orientation of the TR jet. Central anteroseptal jets are more favorable as compared to TR jets, which arise mainly from anteroposterior commissure. And this is then also summarized in the tricuspid focus group in device selection summary, highlighting that the gap should be not more than 8.5. Central gaps are more favorable for annuloplasty or TIA, and beyond, replacement technologies might be quite promising. And then the last aspect I'd like to make refers to how to prepare patients for the therapy, but also highlighting tricuspid regurgitation, the degree of TR, but also the gap very much depends on the volume status of the patient. And you can see here an example of a patient in whom the gap was too large for therapy. The patient was then diuresed, and after diuresis, the gap became much smaller and then was suitable for therapy. So in summary, patients should have high risk, clinical benefit should be likely, not an easy judgment, but pre-capillary hypertension and severely impaired RV function are certainly things to look out for. And then anatomical suitability, look for the gap, the origin of the TR jet, and consider diuresis before therapy. Thank you.
Thank you, Philip. That was outstanding and very concise and clear, I think, for everybody. So clear that is a challenge for Stefan. So, Stefan, this is a simple recipe to define the ideal anatomical candidate. What is your recipe? Is there anything else that you really look to choose the right patients?
First of all, clinically, I would say that the patient is symptomatic, and from an anatomic standpoint, I think very important for at least the TEER therapy is the length of the septal leaflet and the integrity of the septal leaflet. That is another point. It's of course correlated with the gap that Philip has already shown.
Okay, that's an important point, and I would like now to turn on my other side to Pepe. obviously, we look at some anatomical features, but these patients actually, they are very complex patients. So, and always we have to understand when these procedures are futile. What do you think is an easy way to describe a patient where we are too late and the procedure may become futile?
Yeah, thank you, Francesco. I think this is an extremely important question, and mainly because sometimes we are simply treating too late. And we are based in the surgical numbers of high mortality, and this is not the same for transcatheter interventions. So when it's too late, I think that pulmonary hypertension is crucial to exclude mainly precapillary pulmonary hypertension. There is bad news for the patient, bad news for the procedure. Simply, we may need to change the doctor. It's too late. And also right ventricular function. Right ventricular function is crucial. I think TAPSE, and as was shown, is not the perfect method, but volumetric methods for right ventricular ejection fraction implies a good moment to analyze right ventricle.
Thank you. I mean, as I listen to you, I already have a question for João Cavalcante, who is on the other side of the ocean in Minnesota. And, you know, as these patients are difficult to analyze and to judge and to select, can we learn something from advanced imaging? What kind of imaging alternatives we have to transesophageal and transthoracic echo and to right heart catheterization? What is the role of MRI?
No, thank you, Francesco. It's a pleasure to be here and seeing all colleagues. Advanced imaging, we're learning quite a bit, especially through the Triluminate imaging sub-study in these challenging patients. Protocols have to be specific. This is a group of patients that tends to have devices, and historically, we tend not to image them by MRI. It's 2021. We should image these patients. They introduce some artifacts, but we can see not only what the RV is doing, how dilated, how dysfunctional it is. It's a disease that starts in the right atrium, goes in the annulus, and then eventually mixes into the right ventricle. By the time we see RV dysfunction, it's already somewhat recoverable, but we should try to intervene way upstream. CT, depending on the protocol of acquisition, also can provide the RV ejection fraction. We should measure that. The information is there when we assess for transcatheter interventions, and also be able to see the gaps, as Philip highlighted. It's important to see the anatomy. Quadricuspid, tricuspid valves is not uncommon, and all of that would have some challenges and difficulties in the management of these patients.
So I was impressed by the presentation from Philip, and also I take your last comment about the tricuspid valve being sometimes quadricuspid or maybe bicuspid. You know, there is a lot of variability, and I would like to ask maybe Georg, who has a large experience. Do you count the leaflets to select your patients, or you think that's such an important issue?
I think it is an important issue, but it's only one parameter. If a patient gathers several disadvantages, I would say, and then he has 4 or 5 leaflets available and many indentations, he may be not the right candidate to go for. But if he has 4 leaflets, for example, which is not ideal as published by the Leipzig group, then I would still go for him if he or she would be a perfect candidate. So it's one parameter of many parameters to be considered.
Yeah, Georg. So I think basically we have been discussing a little bit about selection criteria for patients. And obviously, already Philip pointed out that based on anatomy, we may select different treatment options. So this is the right time for us to listen from you. What are the options today for patients with tricuspid regurgitations beyond surgery? Obviously, we're focusing today only on transcatheter interventions. So Georg Nickening is going to give us an overview about this topic. Georg?
Thank you very much for having me. So these are my potential conflicts of interest. This is the recent guidelines, and there is a mentioning of a transcatheter approach to tricuspid regurgitation. So this is worthwhile, a message down there for patients who still have symptoms despite optimal medical treatment, whatever that is. We maybe can discuss that also later on. So as you all know, and as already pointed out nicely, tricuspid regurgitation is a right ventricular disease. Usually it starts with right ventricular dilation leading to malcoaptation of the leaflets, secondary, for example, to left heart disease or long-standing atrial fibrillation. And then TR begets RV dysfunctioning, leading to more RV impairment and then also tethering of the leaflets, as you can nicely see on that drawing. And fortunately enough, we have a wide array of different devices available. Some of them have been tested already or approved, and some of them are clinically tested as we speak. I will cover only the devices which are already have been improved or which are at the horizon to be improved for the time being. First of all, we have to talk, of course, about the TEER devices. And the first one is the Triclip device. That's a dedicated tricuspid space device. It comes in 4 different sizes depending on the length and the width of the arms, as you can see here on that sketch. And they are usually meant to bring the leaflets together, mostly the anterior and the septal leaflets, to bicuspidalize, for example, a valve and to reduce tricuspid regurgitation, also have an impact on the annular dilation. And this is data from the Triluminate study, which we all together published quite a bit ago. And it shows you on the left side how many clips to be used. And as you can easily appreciate, you need, in most of the cases, more than 1 clip, 2 or 3 clips. Admittedly, at that time point, we had only a small clip available. But interestingly, also on the right side, and this mirrors also the current clinical practice, where do you usually position these clips? Again, this is data from the Triluminate study. Most of the clips go into the anteroseptal commissure and the remaining 20% in the posterior septal commissure, as you can see here. And just let me make another point for this type of procedure, as we don't talk about outcome too much in this webinar. It's safety. This is safety data after 30 days of the Triluminate study, and as you can also easily read through the table, there was no mortality whatsoever. There was no conversion to cardiac surgery. So it's a very safe procedure, as you can see here on that slide. And there is another possibility to use a TEER device, and that is a Pascal device. It's quite comparable to the Triclip device. It has also independent grasping or clasping possibilities to overcome also larger leaflet devices. It's very flexible, but I would think it's safe to say that it is very comparable to the Triclip device. But remember, tricuspid regurgitation is an annular disease, and therefore it is a smart idea also to think about reduction of the annular anatomy. And the only approved device so far is the cardioband device, which comes also via a transvenous transcatheter approach, and usually implant this device with 16 to 17 anchors into the annulus coming from the anterior to the posterior side, and then you cinch this wire inside this fabric together, shrink the annulus, and hopefully enhance coaptation of the leaflets and reduce the tricuspid regurgitation. Just one piece of data from the TriRepair study that shows you reduction of the septolateral annulus, or the diameter of the annulus, in response to the cardioband implantation. So the device does what it's supposed to do, and it also reduces the tricuspid regurgitation. And then at the end of my talk, I just want to mention that there is something else on the horizon. This is replacement, and most data we have available so far comes from the Intrepid valve, upper right corner, or even more from the Evoke right lower corner, or from the CardioValve device. They have some promising early results, and maybe I can share with you at least one outcome data. This is the assembled data from the from the compassionate use EVOKE study. It's not really a study, but it's just a gathering of the data, but it nicely shows you on the right side that you almost completely can wipe out tricuspid regurgitation, even in patients with more than severe tricuspid regurgitation. So I would like to finish my presentation with this type of scheme. Depending on the severity of tricuspid regurgitation, we have for the severe cases, the annular and especially the leaflet devices available, and for the more desperate cases so far currently, I think we should consider transcatheter replacement devices in the frame of clinical studies. Thank you very much for your attention.
Thank you, Georg. This was again a good summary of the many options which are available. And obviously, the leading therapy is transcatheter edge-to-edge, and I would like to ask simply to Stefan, why transcatheter edge-to-edge is leading also in the tricuspid?
I think because the experience on the mitral valve was so huge. So we have more than 120,000 human implants in the mitral clip, and this was converted to the tricuspid side. The second thing is we don't need contrast. It's a very fast procedure, and it's totally venous from the femoral access side. So we can do this beating heart without involving hemodynamics of the patient. So it's a very safe procedure. We know that in the Triluminate trial, as Georg has shown this nicely, the mortality was 0. The early experience, even with replacement, is between 0 and 3% mortality at 30 days. I think this applies for most interventional techniques, and these are all very, very safe.
Safety is an important issue in these patients, Pepe. I think one of the reasons why surgery gave the position of tricuspid interventions to be the forgotten valve. The tricuspid valve is being called forgotten for many reasons, and one of the reasons is that there is a perception of high-risk procedures. It looks like that the data from the Triluminate study, for instance, shows some safety, and how important is safety to convince our colleagues to send patients earlier?
Well, it's no doubt, Francesco, that having TR in a patient implies bad prognosis. So we need to do something. Why we were not doing surgery for years is because there is a clear increased risk of mortality, and this is close to 10%. So this is huge and has nothing to do with the safety numbers that we have now with transcatheter interventions. So the good news is that we have TR is not easy, but we have a portfolio, we have a menu of different answers to the different patients, and all of those are clearly safer than surgery.
Yeah, I would like to mention that as we start these programs, we start seeing earlier indications and patients who may become again good candidates for surgery. Because I have to say that surgery is high risk in the patients that are commonly sent too late for treatment. If you treat patients very early, it might be still possible to treat these patients surgically, although I think that these interventional procedures are replicating surgical procedures in a very good way. So in future, who knows where the role of surgery will be for isolated tricuspid. But, you know, this is my question now that goes maybe to Philip. You are one of the large volume centers. Do you see patients coming a bit earlier as you demonstrate safety of these procedures?
It is exactly the way you describe it. We see more referrals for tricuspid valve disease in general, and amongst them we also see patients who are actually at low surgical risk. And they are discussed in our heart team. They undergo surgery, and with very good results. So, as very often and seen before, the transcatheter revolution can also be in some way inspiring and make some progress for the surgical community. And I think that's something we see all together, because the creation of more awareness for the disease will be good for the patients and has implications not only for interventional but also for surgical therapy. I'm convinced.
So, Georg, I have a question for you that comes from the chat, which is actually ongoing. And there is one question. In many countries, Triclip is not yet available. Can we use MitraClip? Well, this is obviously we did this. What is your official answer?
Yes, it's an off-label use, but you can use this. You can use it. We had to use it for quite a while. I mean, there is issues with the orientation of the system of the catheter in the device. You have sometimes this septal hugger, which sometimes you cannot overcome with a MitraClip device because there is one bending missing and one rotational aspect of the device. But you can try. I would highly recommend, if you go with a MitraClip for tricuspid space, you should really go for the patients in which imaging is optimal and in which the coaptation defect is not so large.
Okay, that's great. I think we have been discussing quite long on general topics. I think it's time to go and watch all together the case which have been recorded with a virtual live approach in Toulouse. Again, this 75-year-old lady with functional TR secondary to previous mitral intervention, and who was then considered too high risk for surgery and sent for tricuspid intervention with something that we will discover soon. So let's see the video.
So welcome to Clinic Pasteur for this live case focusing on a tricuspid regurgitation, a patient with a severe tricuspid regurgitation. It's a real honor today to work with my friend and partner, Nicolas. Laurent will be the echocardiographist today, Anne-Laure the anesthesiologist, and Rosa and Claire will be the nurses guiding us, helping us treat this very complex patient. So Nico, they have discussed the case and we have a strategy. Could you tell them why we decided to go for such a strategy?
Yeah, briefly to summarize, Didier, this patient is for sure a high surgical risk patient. So in our algorithm, we decided to go, if possible, for transcatheter therapy rather than for a surgical intervention. Now, thinking about transcatheter therapy available in our centers, we have edge-to-edge tricuspid repair available, commercially available, or in the context of clinical study, the possibility to implant transcatheter tricuspid valve. Here, more precisely, and even we are beginning with our experience of transcatheter tricuspid valve implantation, we saw in the CT scan that the right ventricle cavity is quite small. The angulation between the inferior vena cava and the right ventricle is not ideal. So those were anatomical factors that were not ideal for transcatheter tricuspid valves. So we went for transcatheter tricuspid edge-to-edge repair, namely with a Triclip that we're going to perform right now.
Okay. So Francesco, Stéphane, and Pepe, welcome. If you don't mind, I would like to hand over to Laurent, and Laurent is going to drive us through a couple of echo views, and then we're going to start the case and our live discussion. So Laurent, the floor is yours.
Okay, on the inflow view, we have an anterior-posterior view of the tricuspid valve with a biplane. We can see on the image on the right, the septal leaflet and the anterior leaflet. As you can see, there is a gap in the anteroseptal commissure, and the septal leaflet is not really seen. If we move now posterior, just first with a color Doppler, you can see there is a regurgitation in the anteroseptal commissure. Now, if we move the cursor posterior, we have the posterior leaflet and the septal leaflet. And again, with color Doppler, we can see that there is a regurgitation in this commissure. We analyze the mean gradient of the tricuspid valve. It's around 1.6 millimeters of mercury. And if we move to the transgastric view, in short axis, we have the anterior, posterior, and septal leaflets. And using color Doppler, we can confirm that there is a severe tricuspid regurgitation with a jet, I think, all around the septal leaflet in the anteroseptal commissure and posteroseptal commissure.
So thank you very much, Laurent. So Francesco, we're going to start the case. Would you like to tell us about what would be your strategy for this patient?
Yeah, so it is not an easy case because obviously the jet is overall in the full line of coaptation of the septal leaflet. So, you know, this patient would be probably in the future, we will see more and more cases of replacement in these cases. I would like to ask the question to Ralph at the moment while you are preparing your device. Ralph, what would be your strategy here? Tear or replacement, if in an ideal case, let's say where you can do anything?
I think we have a very favorable anatomy. We have long septal leaflets. We've seen that the gap in the four-chamber view is not excessive. It's elongating from anterior to posterior. So, we have a relatively still preserved small right ventricle. So my clear favorite would be a repair situation.
Okay, so Didier, you move forward. I think you should tell us exactly what you're
doing
at the moment.
So what we did was to, we have a dedicated system. Maybe, Nico, you could tell us what we have in terms of features of this Triclip device. And Baptiste, could you zoom on this, on the box, please?
Yeah, so perfectly. You see here the guide, so the long guide that is entering from the femoral vein into the right atrium. For those who are familiar with MitraClip, of course, you see something that you're familiar with. What has just changed is that with this knob here in the guide, you can adjust the deflection of the tip of the guide towards the septum by rotating in this direction or towards the lateral wall. Whereas conventionally, as we did also on the mitral side, by just rotating clockwise or counterclockwise, you can adjust the trajectory of the tip of your guide, either also septal by rotating clockwise or lateral by rotating counterclockwise. Now, if we go to this part of the delivery catheter delivery system, you see that as compared to the MitraClip one, because again, visually it's really close, really familiar, you just have one knob, and I'm sure you're reading the letters that are here. It's visually very, very easy to understand. If you turn this way clockwise, you will flex the tip of a delivery catheter, and in other words, you will be able to dive to the axis of a tricuspid valve, and then you will adjust that. And on the opposite, you will correct this flexing movement. And we'll come back to that during the procedure. But again, here, as we do for mitral, it's mainly all about the trajectory coming from the right atrium to the tricuspid plane and to the tricuspid line of coaptation. And on the distal and last part of the delivery catheter of the handle, we have all the commands that allow us to control the clip lock line, the grippers, and the release or the opening of the arms of a clip and the release of a clip. This is quite conventional and nothing new about that.
Thank you very much, Nico. So if we come back now on the Furo, what we did was to apply a minus, excessive minus on the guide catheter just to straighten it. And we're going to do the reverse straddling. Usually what we did for the mitral position was to advance the clip delivery system just to align both part extremities of the straddling feature of the clip delivery system from part to part of the tip of the guide sheath. Here it's going to be the opposite. It's more that we're going to do we're going to retract the guide sheath just to get into position. So having said that, maybe we can go with retract a little bit more. And I'm going to, as Nicolas has said, I'm going to flex a little bit. So we pay attention at the same time on the echo. Nicolas is retracting, withdrawing the slack. And I'm meanwhile, going to flex a bit. So we need to find the proper position. So I'm going to withdraw part of the minus that we had in the system, just to get closer to the tricuspid valve. And already, probably, Nico, you could rotate a little bit the clip just to be more in the axis and more perpendicular. Okay.
We lost our straddling a little bit.
So let's correct the straddling just to get opportunity to take opportunity of all the features of the device. And now Laurent is going to tell us about what we have.
I think it's a good time to ask Pepe, Stefan. There are challenges in this case in terms of echo. What are the alternative solutions? Would you think about ICE?
I think that there are a couple of things, Francesco, that really matters here. So, in fact, when you are moving towards the interlateral septum, this means it's towards the septal aspect, because in fact the septal leaflet is posterior. If you move toward the superior vena cava, you are going to touch the anterior leaflet, because the anterior leaflet is superior. And if you move downwards, you really go through the posterior, because the posterior leaflet is really inferior. What is also really relevant, I think, from the imaging perspective, is that in your fluoro, if you go to the cranial and to the right, so this means you will see the three-chamber. So in fact, I think that we should call it three-chamber view. And when you go caudalis, and to the A, then you will see the two-chamber view, which is the opposite as what you see in the mitral. So I think that here is a real challenging case, because you don't really see, or you have some problems in really depicting the three leaflets here.
So here what we see, if we analyze just the trajectory, we've opened the clip a bit. It seems to dive more or less towards the apex of the right ventricle, so that's a good sign. So now why don't we focus on the transgastric view, the deep transgastric view, just to see where we are and decide on the location in which we're going to put the clip here.
I think we can do quickly. Myself, I would with the. Are you using an XT wide at the moment? Correct.
Yeah.
So with XT, the approach usually today is to attempt a central clip in the anteroseptal, let's say, line of coaptation. So going in the middle of the valve rather than in the commissure like we were doing in the past. So I see Stefan nodding, so you agree with that? So it should be there, right? It's a little bit more of a challenge to understand the orientation towards the line of coaptation. And so maybe I ask Stefan, what do you use? Transgastric view to get the orientation right?
Yes, we in mine since 2017 try to use mainly the transgastric. We control especially the septal insertion, also in transesophageal use. But typically you start anterior, as you said, on the anterior to septal leaflet, because otherwise you get shadows in your transgastric imaging. So you should always work from anterior to posterior. That is advisable in the tricuspid. And the orientation here would be 2 o'clock or 2:30. To 8 o'clock or 8:30. So slightly rotated counterclockwise from the horizon. That would be my recommendation, because you see that the free anterior leaflet retracts a little bit to the upper left here in the transgastric.
Why you many they already grasped, I think.
Yeah.
we are just slightly below or touching the leaflet, just for, as Ralph Stefan was mentioning, just to correct the orientation of the clip. And it's not fully at 2 o'clock, but we agreed that we should try to achieve that. So let's work on the imaging. Pepe, you nicely highlighted all the challenges of this case, imaging-wise. But here, if you keep stay like that, maybe we can rotate a couple of degrees counterclockwise, just to match what we said, and be a little bit more like that. Would you agree with that aspect?
Yes,
absolutely.
Yes.
I think with the free wall side, with the anterior side, you were already in the in the interchange between the anterior to posterior leaflet. You have to be definitely in the anterior leaflet. This is why you cannot do in this case 3 o'clock to 9 o'clock. So 2 o'clock to 8 o'clock is vital. And you can turn, when you close, you can turn slightly clockwise, but you have to start counterclockwise to be surely in the leaflet and not in the indentation between the anterior and posterior leaflet. That's very important. Yeah, now it's better. Yeah. And
so let's try like that. Mets-nous la couleur, s'il te plaît, Laurent. So we are grasping. Let's see on the...
Now you have it.
Voilà. Let's see with the echo what it does, and you see the decrease of the... There is still something, but we need to assess that. So let me retract, release a little bit of the tension, and then let's assess.
It's better now.
Location is okay.
Yeah.
You see the beauty of the transgastric view, actually. Yeah. So you see the lines of the leaflet edges of the leaflet tips running into the clip system. I think transgastric is a game changer in tricuspid.
And I think when you say you still see something of TR, well, this is really, really frequent. Nothing happens with that. Yeah. So we should not expect that the TR disappears completely.
First of all, I think now, usually at this time, I finalize one of the important questions. Is it the anterior leaflet single or splitted? Sometimes you don't see it well before the procedure, and you may see it now. So it looks like this is a typical tricuspid with a single and large anterior, and the posterior leaflet looks also single leaflet. So probably I would go for another clip in the anterior, maybe, or maybe we can think about going to the posterior. Let's see. I never take decisions before I release it. This is something you need to understand after you release any tension. So as you do all these maneuvers, which are more technical, I will ask a question to Pepe, because soon we have to take a decision. And the question is whether in a patient you accept moderate, less than moderate. What is your overall, generalistic target? You like to have a reduction? You like to have achieved the best?
Well, I think that you need to decide, obviously, case by case, because it depends on if you use more than one device, what happens with the gradient and so on. But assuming that you will never, or very, very seldom, only one in our hospital get 0 TR, I think that less than moderate is a good result, or I will say less than 2 grades below the basal. So if it is torrential, you can move to moderate. It will be an excellent result. If you are severe, then you try to achieve mild. So at least 2 degrees going downwards is an optimal result.
So then this is the question to Toulouse. So what did you achieve?
You heard our friends.
Yeah.
So how would you comment what we have in terms of results?
I think for the moment, and we still have a significant tricuspid regurgitation. We should continue, I think.
Yeah, I agree. What is the gradient now? Is 1?
Mean gradient is 1, yeah.
Yeah.
Should only be a slight change to the first clip. So I think counterclockwise could be the right direction, but you see it better in the OR.
So it seems just given the orientation of the septal leaflet, I would have gone more that way.
Yeah, but anyhow, you are engaged on leaflets.
Yeah.
I would close the leaflets and
see. Let's try here
and see the effect, because could be not bad. I mean, you have a nice grasp.
A bit of color, Laurent. Thank you.
Yes.
Let me release part of the tension. We have some kind of central jet now.
It looks like only there.
Yeah, only here. So let's try to assess the regurgitation that we have. Laurent? So what,
I think we reduced the tricuspid regurgitation, but I want to be sure that both leaflets are well in the device.
If you add some color here.
This was what I was going to say. Sometimes color helps.
Yeah. In terms of color distribution of the regurgitation, it seems to be less than what we had before the second clip, for sure.
It's definitely an improvement. This case is challenging because of the shadowing of the mitral prosthesis, that's for sure. So
I think the two leaflets are inside, and I think we significantly reduce the tricuspid regurgitation with a residual tricuspid jet between the two Triclip.
And in terms of gradient, if you could just tell us some measurements, just to see if we didn't increase too much the gradient. There is a gradient, so definitely we did grasp the leaflets. But to which extent this gradient is acceptable, you're going to tell us now. So it's really about that multi-parameter assessment of everything, and the gradient went, it went from 1 to 2.7. So it more than doubled, but it remains below 3 millimeters of mercury, even 5. So that's what we have. Given all the challenges, I guess it's quite an acceptable, more than an acceptable result for this lady. We already have more than 2 grades reduction in terms of tricuspid regurgitation, no gradient. So it's all about the discussion now, Nico, is going to be about if we think that this is going to be stable or if we need to stabilize that furthermore.
So on the inflow view, if you look at the image on the right part of the screen, we can see that the posterior leaflet is not, I think, fully engaged in the Triclip. That's why maybe the clip is mobile. And if we look in the transgastric view, after we release the clip, we can see that the device is mobile with a significant tricuspid regurgitation between the two Triclips.
Okay, so we have that clip that is slightly mobile, and here the gradient is 2.7.
Gradient 2.7.
Okay. So there is partial mobility. It's still attached to the posterior, Nico, it seems, but the movement is too important. So it seems that we need to stabilize. So we're going to put a third clip. And the goal, if you agree, Francesco, Pepe, Stéphane, Nico, Laurent, would be to put that third clip exactly in between the first 2 ones.
Yeah.
So Nico, would you summarize the steps to achieve that?
Yeah, so again, same philosophy that what we did over first, be sure of our trajectory, coaxial to the RV long axis, perpendicular to the tricuspid plane. Fluoroscopy, quite easy to position in between the 2 clips. We can use the first one to more or less orient the arms of this clip, and very important to enter the right ventricle with the clip closed. And once we'll be in the right ventricle, as you just did, Didier, we're going to open the arms, check the perpendicularity to the coaptation line between the 2 leaflets, and then try to grasp. So while I was speaking, you already did partially that, Didier. We are now in the right ventricle, just below the tricuspid valve, in between the 2 clips with good trajectory, and you see that on the right side of the echo images. So let's open the clip here.
Just to confirm that we are below, keeping an eye on the fluoroscopy just to appreciate the interaction with the first ones. We're gonna slightly, okay, it seems to be okay. We're gonna go now.
You're a little bit deep, huh?
Briefly into the transgastric view, Laurent. Very briefly, just to confirm our location. And potentially correct partly our orientation. So here it could be, it's close to be okay because it has to be quite parallel to the first one. It could be slightly counterclockwise, very gently. Yeah. I'm going to do that on Furo just to make sure that we don't have any major interaction with the first one.
The other thing you can do here in this view, the second clip was attached to the septal leaflet for sure, and you can see here that for sure you are beyond the second clip. Sorry, so for sure you have septal here.
Let's see what we get, Nico, once everything is released, and then we're gonna give the final words to Laurent and yourself, Francesco.
Okay. So, as you can see in color Doppler, I think we significantly reduced tricuspid regurgitation. Now we have a mild residual tricuspid regurgitation between the clips, mean gradient is around 2.5 millimeters of mercury. So I think it's a good result. So in transgastric, the first clip was implanted here, and we have the two posterior septal. And in color, because of the shadow, it's not easy to see the tricuspid regurgitation, but
yeah, it's really
the residual tricuspid regurgitation is here.
So Francesco, the floor is yours for the final comments.
So I think it was a great case demonstrating that imaging plays a major role in tricuspid, and whenever you have challenging cases like this one with the previous surgery and shadowing from the valve, there is a lot of challenges. It was also challenging in terms of anatomy, but at the end you achieved a result which probably will have a significant clinical meaning. I think this will be matter of discussion in our arena. I think already the comments from Pepe and from Stefan have been very valuable as well, because tricuspid remains an area which is work in progress, and we have to learn from each other. We have to share our doubts and our ideas. In the meanwhile, we have seen one patient who benefited from a non-invasive procedure, having a valve repaired with a very good final outcome with a minimal TR. And so I would congratulate Toulouse for the excellent broadcast, and thank Pepe and Stefan for helping me to run this virtual live at PCR London Valves. No, sorry, it's not London Valves.
It's a webinar.
So I would like to, so I will do it again. I would like to thank the whole team in Toulouse, because I think it was a real team effort. You have seen that, how many decisions have been taken. I would like to thank Professor Zamorano, Professor von Bardeleben for helping me discussing this case, and I'm sure that we're going to discuss even more during the webinar for the PCR tricuspid focus group. Thank you very much, and see you soon.
We are back here. So again, it was a challenging case for many reasons. Mainly, I think imaging has been the main challenge. So I will take the opportunity to ask Stefan. Stefan, what to do? I mean, in most occasions, we can run the procedure using this inflow, outflow, and explain. But in the old time, we were using a lot of transgastric. Is there a role of transgastric today?
Yeah, it's like coming back to the early days of mitral procedures that actually started for the rotation with transgastric views. And actually, there has been a revival of this view in tricuspid procedures. And it's very important to train your interventional echocardiographer in these views to be very competent, to know the right angulation, to control possibly the position and the flexion of the TOE probe in fluoroscopy. And I would also like to highlight that we have a third view, which is the deep transesophageal view, which was difficult in this case because the right atrium was too small and the position of the esophagus was a little bit too much behind the also diseased and enlarged left atrium. This was why we couldn't overcome in the transesophageal views the bioprothesis that much. So it's also important perhaps to have a backup like an ICE catheter in your lab for isolated cases, but most procedures can be done even with aortic and mitral bioprothesis with the transgastric view.
Okay, and the other point about this procedure has been the complexity of the decision making. Has been a lot of decisions taken during the procedure. So I would like to ask first, Pepe, how far we can go in the prediction when we look at the patient coming. Can we predict if this is a patient requiring only 1 or 2 clips in a commissure, or we have to go for 2 commissures? What is the level that we achieved till now?
Well, I think we can certainly predict something, and once we clip the first septal and maybe anterior or posterior leaflet, we need to see the reduction in the volume. Also, reduction, you immediately see a reduction and changes in the inferior vena cava, and also as the gradient is also important. So if we have a gradient that is 2 or 2.5, as we have seen today, is a nice result with a reduction of the TR severity. So I think in summary, because I was fully in agreement with Georg, one parameter is not enough for TR. We need to look to the whole picture.
Okay, and so I will jump back to our colleagues who are connected online and ask. So this patient, if you recall the anatomy, it was the regurgitation was through all the line of coaptation from the anteroseptal commissure to the posteroseptal commissure. So in these patients where in general we think we need to implant 2 clips, I would like to ask both Georg and Philip, you go for 2 clips, what kind of clip size you use? Is there still a role for shorter clips? Are you using wider clips? What is your recipe overall? Let's start with Philip. Sorry.
So my general approach is to use long clips and probably also the wider ones. And the other general concept for me is to implant as many clips or devices into the anteroseptal commissure to close off that completely, but at the same time pull over the RV free wall towards the septum and thereby get some indirect annuloplastic effects as well, which normally then will give you some reduction in TR away from the side of the devices where you implanted those. It doesn't always work, but my concept is more focusing on anteroseptal and not, and most of the time stay away from posteroseptal.
Good. So this is one recipe which is very often followed. So I would like to ask Georg, do you go for clover-like procedures, or you also like this approach of getting additional septolateral dimension reduction with additional clips?
It depends on the case. I totally agree with Philip's approach, by the way. I would also use the wider and longer clips. Why torturing yourself? And if you are able to place the first clip already in the very central spot of the anteroseptal commissural line. You may get away with one clip, but usually that's not the case, and you need two clips in the anteroseptal commissure to pull over the annulus. So I totally agree. But still, we are tempted to use another one in the posterior side if there is still a residual regurgitation, which is frequently the case. So it all depends on the cases, but I wouldn't be too dogmatic about the strategy. See what you get after the first clip and then make a calm decision for the next one.
So thank you, Georg. I think we have to go into the conclusion. I think the idea here not to be dogmatic about the procedural strategy does not probably apply to be dogmatic in how do we assess the outcome of these patients and what is the parallel between what we achieve during the procedure and what we will achieve as a clinical benefit. Actually, this will be the topic of the next webinar, which will be focused on clinical outcomes, targets of therapy. We will talk about lifetime management of these patients because remind that this is not a one-shot procedure. We are talking about very complex patients. And last but not least, the last webinar will also focus on the next generation, on the innovation around this field. So with this, I would like to thank all the participants, and I would like to really invite everybody to follow the next webinar, which is going to happen on December 9th at 18 or 6 p.m. Central European time. And I hope that you will enjoy the final step of this patient pathway from diagnosis to therapy to lifetime management. Thank you again very much and see you soon.
Thank you.